Now let's discuss some ways to decrease contractility. So if you can increase contractility with beta adrenergic stimulation, would it make sense that beta blockade will decrease it? Of course. So a beta blocker will be a great way to decrease contractility. So heart failure with systolic dysfunction is another cause of decreased contractility. Why? Heart failure with systolic dysfunction means that the ability of sarcomeres to expand and shorten has been lost because we've overstretched our sarcomeres. You're not going to be able to properly create those crosslinks required for contraction. Now what about acidosis? Acidosis will also cause decreased contractility. This is a tricky one. The high proton or hydrogen ion concentration will actually compete with calcium on these L-type calcium channels. That means that you will have decreased ability to have calcium-induced calcium release because these protons are directly competing with the flow of calcium across that pore of this L-type calcium channel. Hypoxia and hypercapnia will obviously decrease cell respiration. So if we have low oxygen and high carbon dioxide, which is hypoxia and hypercapnia, that you will directly decrease cell respiration. And that decreased cell respiration means we have less ATP. Remember, the hydrolysis of an ATP molecule is necessary to take our myosin head from the end of the power stroke back to the cock-loaded position. Non-dihydropyridine channel calcium blockers block the flow of calcium across these L-type channels, which has basically the same effect as competing, just like these protons do. This leads to an overall decrease in intracellular calcium. So what about myocardial oxygen demand that's listed on your page in your first aid book? Things that make the heart work more increase myocardial oxygen demand. Just think about it as if you were working out your bicep. This is your arm because you're absolutely jacked, and this is a 10-pound weight in your hand. So if you increase the afterload, which means that you decide to pick up a 20-pound weight, and your bicep is the same thing as your heart muscle, you're going to need more ATP for contraction because you're going to need to recruit more myosin heads for that next power stroke because you have an increased force requirement. To recruit more myosin heads, you're going to also have to hydrolyze more ATP to restore them into the cocked position for the next power stroke. All of these are related back to the use of ATP, including the increased contractility, heart rate, and ventricular diameter. The increase in ventricular diameter will also stretch the sarcomere and create more myosin-actin crosslinks. But you'll also need more ATP to have that myosin head dissociating and returning back to its original position. Now let's expand more on the preload. As we mentioned before, preload is equivalent to the ventricular end systolic volume, or the volume of blood before contraction. What determines how much blood is present in the ventricle at the end of diastole? I'd probably go with how much blood volume you actually have and the tone of whatever vessels are helping propagate blood back to the heart. Veins are the key player here. They help return blood back to the right side of the heart. Venous return is driven by the pressure difference between the veins and the right atrium. Let me write this out for you because this is incredibly important. So venous return, venous pressure minus the right atrial pressure. So if I was to increase venous tone, which means I would have venoconstriction, this would actually increase our venous pressure. And that means we will have a greater difference, which means that we will have an increased return to the right side of the heart. On the other hand, if I were to give you some nitroglycerin, the veins would dilate. So I give you nitroglycerin, and this causes dilation of the veins, and this means you have a decrease in pressure, and that decreases the difference between the venous pressure and the right atrial pressure. That means we have decreased return, and therefore a decrease in preload, and that is the basis of giving someone nitroglycerin that's having angina. By decreasing the venous pressure, we decrease the return to the right side of the heart, decrease the stretch of the sarcomeres, and decrease our oxygen requirements because we will not have to use as much ATP or hydrolyze that much ATP to return our myosin heads to the cocked and ready position. This is the fundamental physiology behind understanding some of the therapeutic modalities for treating myocardial infarction. We just said that by causing veins to dilate, you decrease the amount of blood that is moving back to the heart. Remember, this decreases the stretch of the sarcomeres in the ventricles. By decreasing the ventricular diameter, you do not stretch the sarcomeres of the myocardium, and therefore prevent them from requiring such a high oxygen demand. So, less stretch means decreased number of actin to myosin interactions, and therefore you need less ATP to reload the myosin head. You essentially decrease the requirements in the ischemic muscle to help it recuperate because the coronary arteries are already struggling to provide it with oxygen, which is why these patients that had an MI in the first place. Now afterload. Afterload is equivalent to the mean arterial pressure, which is proportional to the peripheral resistance. Remember that our total peripheral resistance is equal to whatever our precapillary arterioles are doing. These small vessels are under the control of the autonomic nervous system because they have smooth muscle that contracts when alpha-1 receptors on them are stimulated by an agonist such as norepinephrine. These are stimulated to contract. This causes an increase in TPR, or total peripheral resistance. I think this is an important time to incorporate afterload as you would see it in clinic, which would be hypertension. Let's discuss an important concept that will show up also in the pulmonary physiology section, the law of Laplace. So if you imagine your left ventricle, this component here is wall thickness, denoted as N. Then we have our radius, our pressure within the chamber, and then wall tension, which will be denoted as sigma, and the radius is R, of course. The law of Laplace is wall tension equals the chamber pressure times the radius divided by wall thickness. Now normally this is times 2, but I've never seen any question requiring you to calculate the actual wall tension. It is more of a conceptual equation that helps you reason through a lot of the pathophysiology that we will later discuss. So when blood enters a chamber of the heart, the filling will create stress in 3 different directions. It will cause elongation of the circumference due to wall tension from the chamber trying to expand, so in this direction, elongation of the axial length in this direction, and compression of the wall thickness, so in this dimension as well. And that's in the direction of the radius due to the pressure from the volume of fluid that's increased inside the chamber. Pressure in this equation is actually the transmural pressure, which is the distending force that is caused whenever you try to make a ventricle fill more than it's used to. Directly fighting against this filling pressure or force is the wall tension, which we wrote as sigma. As you can see, it is kind of hugging the components of the chamber and will push back. It is the force that wants to constrict the chamber back to its original circumference. The radius of the chamber, not including the ventricular wall, and the thickness of the myocardium are the 2 remaining components of the equation. Why do you think that wall thickness is in the denominator of this equation? Well, let's think about it clinically. If someone is suffering from chronic hypertension, why is it that their myocardial wall will be thicker than normal? Well, just like we talked about when you have that 10-pound weight in your arm and you increase it to a 20-pound weight, that increased afterload will require our heart to pump much harder. The afterload is greatly increased from hypertension, and the heart does this by adding sarcomeres in parallel. So we add sarcomeres in parallel, and this increases the thickness of the myocardial wall, and it will do so towards the center, or centripetally, or concentrically. Those are the terms that will be used on your exam. So if you look at the equation, add thickness to our myocardium, that means that we increase the value in the denominator, and that means we will be dividing by a much higher number here, causing a decrease in the wall tension, which is good. We want an overall decrease in the wall tension. But we also can see that by adding the sarcomeres in parallel towards the middle, as we saw here, we decrease the radius of the chamber. So we decrease this value here. And that is how it will come at an expense, because even though we're decreasing the overall wall tension, because we're increasing our denominator here, decreasing one of our numerators, which is the radius. So this decrease in wall tension comes at the expense of decreasing the chamber radius, which will eventually catch up to us later, as we'll see when concentric hypertrophy can lead to heart failure. So this is the basis of how high afterload in the case of hypertension will lead to concentric hypertrophy. You add sarcomeres to increase the surface area of the ventricular muscle to more easily distribute the wall stress. Now what would a vasodilator do to our afterload? So a vasodilator, like hydralazine, will cause arteries to vasodilate. That means that we decrease our mean arterial pressure. Remember, mean arterial pressure is dependent on TPR. Hydralazine acts at the precapillary arterioles, which determine the TPR. So by decreasing the total peripheral resistance, we decrease our mean arterial pressure, and therefore we also decrease our afterload. This will increase cardiac output in a normal person because there's less of a pressure to push blood against.